Hello. Sorry, I was running behind. You there, Karina? Make sure that, yeah. Um, Karina, can you hear me?
Yes, sir.
Awesome. Um, Sorry, I'm running a little bit late here, but you guys always get me a little bit late, but have the benefit of having me a lot longer, honestly, because my first class, I have to wrap up pretty quickly, but for y'all, I can extend it a little bit more. Um, it might just be us two tonight. If
It
that's the
looks like it,
case,
huh?
if, if that's the case, um, we will absolutely we can talk about anything any topic that you want to related to the class um, and I do have quite a bit I want to cover tonight
Mhm.
um, and probably need to at least for the recording so that everybody can have the benefit of that. But um, yeah, we have a little bit more flexibility.
All right,
Sound
awesome.
cool.
Thank you.
How are you
Mhm.
doing, by the way?
Pretty good, pretty good. How about yourself?
I'm hanging in there. I as you might have seen in the email, I was retained in that forensic case
Yeah.
um, that has ended up being actually the reason why I haven't gotten my recordings out yet. But um, it's it, it's one of those things that is like a once in a career kind of a opportunity and I'm trying to do as a good job, and I'm nervous I'm not going to do a good job, but um, ended up having like a 95 to like 120 page preliminary report that I wrote last week for it.
Oh,
Yep, it's like writing a dissertation. Um,
pretty much.
yeah, but it's yeah, it's just been a whole lot, but it hopefully will be good experience, and so far it has been. It's just kind of taken me away from the time that I was hoping to have to get some of the videos posted. But my plan is uh, as to either finish those up and post those by tomorrow. At least, I know it's at the end of the semester, but at least you guys would have the links to see all that stuff, and
Mhm.
then and or um, offer one more class, not to make your final exam week complicated, but another optional class, either Wednesday or Thursday evening. And I know Thursday is officially the last day of class, but I mean, grad school is kind of different where it's not so much about the timing as much as it is like y'all are on a journey. We're gonna we'll be available even during the breaks if needed. But for sure, either the videos will be posted or we'll have one more extra class and or both possibly. We'll see. Yeah.
Oh,
Um, well, uh, before I jump into covering everything, I'd be more than happy to open it up to you to answer any questions or talk about or clarify anything further that we've covered so far.
well, one thing that I didn't get a chance to go back and review, but I'm not sure whether it's a fair question because it is one of the midterm questions.
Okay.
And I still have two attempts left, so I don't know whether it's
Oh yeah, yeah, yeah.
fair to ask that question.
Hey, that's the benefit of coming to class
Hmm.
is I won't give you the answer, but you and I both will be confident in your selection of the right one. How about let's say that?
All right. Okay. I remember we discussed it a few classes ago when we talked about ADHD,
Hmm.
but I do remember some of the concepts, like the benefits of using medication during the childhood years so that it helps shape the brain differently,
Uh-huh.
and um, and that if used earlier in life, then that medication may possibly be weaned off as the individual ages and progresses, where if medication is introduced later on, it may just be for good that they need to remain on it.
Correct.
That's kind of what I grasped from it. But one of the questions ask about what's most effective, medication, psychotherapy, and I couldn't choose because the idea that I walked away with was it's most beneficial when used combined, right? When we do psychotherapy or counseling and possibly medication together, not like medication alone or psychotherapy alone. And none of the options had that combination. It was either or type of deal. So
Number
again, I
28.
have two attempts, so I can try one, and then if that one doesn't work, I can try the other one, and I'll I'll get it right. But that would be a good review question just for knowledge.
Sure. And that's a great question, and completely understandable why that would be a little bit confusing for sure, because I have I have personally contradicted what the question is asking. And here's the thing is that it's it's a tricky question mainly because I've told you guys the clinical side perspective of it, my my perspective of it, plus based on I would say at least some of the research literature, but taking further steps beyond what we 100% know. And number 28 on that midterm is what you're talking about. And the question is based on the research literature, the
Mhm.
most effective treatment for ADHD is A, psychotherapy, B, ABA therapy, C, pharmacological intervention, or D, none of the above. And that question is tricky because it it hinges on the first part of that question, which is based on the research literature. And unfortunately, at this time, that the research literature shows that only medication is effective at treating ADHD, and that um, even if you combine medication with so-called therapy, hang on one second.
Yeah. Hmm.
Um, so with psychotherapy, as a combination with the medication, um, there's no research to support that it adds anything to the effectiveness of medication alone.
Okay.
Now, with that being said, what I told you guys, and this is what I firmly believe, and where I would say the research literature has us, but hasn't confirmed 100% yet because you can't really measure it very well. The research that looked at ADHD uh, therapy combined with medication, the type of therapy that they used was CBT.
Hmm.
Now, that's because really CBT is the only official gold standard, objective, like quantifiable type of therapy that we can even measure.
Hmm.
That's not to say that other forms of therapy aren't effective. It's just that the research hasn't the research can't measure the other types of therapies, and it can't quantify um, those types of therapies in relation to medication and its effects. In other words, CBT probably, as it was standardized in their research that they did, that's probably not effective. But parent coaching, um, executive functioning, specific types of intervention, like coaching and counseling, even for as integrated into like play therapy, probably is effective and probably when combined with medication works better than both. I'm sorry, works better than either one alone.
Mhm.
It's just that we can't officially measure it
Mhm.
because there's no
Yeah.
standardized, like, in other words, CBT is the most concrete form of therapy that you can actually look at like a medication, like there's a dosage, right, of like CBT. But what nobody knows what the dosage is for parent coaching or parent training, but we do know that parent training in general is effective for ADHD. It's just that we can't really quantify it, and so the research literature won't support it as a primary
Mhm.
form of treatment. And you can even look it up in the American Pediatric Association. Behavioral intervention is second to pharmacological intervention for ADHD, and that's because the research can only measure medication and CBT, and it can't at this time measure very well other forms of therapy which are probably effective.
Okay. Thank you. That
Yeah,
that clarifies a lot. I appreciate it.
yep. And I'm sorry that's a confusing question. It's just that I wanted you guys to remember that the research literature, and really the whole point of that question is that when you work with parents and they have concerns, they're like, well, we're not going to do medication, we're only going to do, let's just do therapy. I want you all to remember that it might be a good idea to educate those parents about the fact that the research is clear. Medication in almost every case is required in order for there to be any improvement of symptoms.
All right. Yeah, I didn't focus that much on that first part of like based on the research literature. I
Right,
just read it kind of quick,
right.
and but yeah, it totally makes sense. Thank you.
Sure. And again, I probably made that question needlessly more complicated by having that caveat, but it's it's an important distinction to make because I get a lot of parents that are just 100% opposed to it, and they say, well, we're going to do therapy first. And when I can't convince them to consider medication, I know that there's a really good chance I'm going to see them in about 6 to 8 months, and they're going to be asking me all kinds of questions about what types of medication are going to be the most effective because they're going to go out and try to do therapy by itself, and it does not work. Like it doesn't work. Um, Medication plus the right type of therapy probably works better than either one alone. But in my opinion, therapy by itself probably never works for ADHD. And the last point I'll make there is that, and it makes logical sense that it wouldn't work because the frontal lobe's job, and this is true for kids and adults, the frontal lobe's job is to be able to learn a skill in this one context, like let's say a therapy hour, and then independently remember to use that skill at school or at home or at work. But ADHD affects the same part of the brain of that skill where that skill is located. And so the neurological capacity for taking a skill that you learned in therapy and independently applying it in the real world is much lower, if not completely non-existent for people with ADHD. So neurologically, you can't expect people with ADHD, kids or adults, to take what they've learned and independently apply it in the real world. They will need a surrogate frontal lobe, whether that's like a smartphone, a teacher, or a parent, to prompt them, to self-monitor for them and say, hey, now's a good time for you to use this skill that you learned in therapy. Now's a good time to apply it in this context.
Mhm.
It's the same reason why kids and adults with ADHD in counseling never ever do homework. They're not very good at doing homework. And that's okay because it's part of their neurology, but you have to work around it. They will do it 100% of the time if there's a big enough reward for them. So, for example, I had a patient one time that was self-pay. He was a college student and just was tired of ADHD and was doing the medication route. That was helping. We were doing individual counseling and could not do, therapy homework or take what we learned in therapy and actually apply it independently. Also struggled with like college homework. But so what I did was, uh, for 2 or 3 sessions, I said, hey, I tell you what, if you do your homework, if you get half of it done, you'll get half of my fee off next session.
Mm.
Just to We did it just as kind of an experiment just to see, would that reward be enough to cause the frontal lobe to have a dopamine push to actually get the homework done. And lo and behold, guess what? They got their homework done.
Mm.
Mm-hmm. I didn't keep doing that because I can't afford to see people for free. But um, we used that principle once we identified that it does work to design ways to reward them whenever they were completing things that their frontal lobe otherwise didn't want to complete while at home, such as like academic homework. Yeah. So anyway,
Mhm.
yeah, yeah. I'm going to share my screen and didn't realize thought I had my PowerPoint slide already up. It didn't. Um, I'm gonna work backwards a bit tonight to cover some of the topics. And Sarah, the only thing that you missed that I said earlier was that I am one. I'm sorry for not posting the videos. This forensic case has had me completely wiped out with my time, um, much more so than anticipated. But I'm either going to post the videos tomorrow, or I will offer one more class between now and Thursday evening. And I realize that y'all have midterm exams, and if you can't make it, that's okay. If nobody shows up, I will record a lecture and post it for everybody. But um, I'm planning on either trying to get those recordings finalized or offer one more class between now and Thursday. Okay. I wrote 95, actually, it was 120 pages worth of references cited, page expert opinion last week. That's what held me up. And so it's not y'all's fault. I just the case that I'm on is in the national news at the moment, and that's all I can say about it. But it's I'm probably overdoing it, trying to do a good job. Yeah. So anyway, Um, what I definitely want to cover tonight and try to get through as much as I can on it. Um, did we talk about how, I don't think we've talked about PTSD yet, right? Correct. Okay, good. Um, I want to cover PTSD and OCD. Um, I want to talk about the oppositional and disruptive behaviors and defiance, things like that, conduct disorders, and then emerging personality dysfunction. And so I'm going to try to do that as quickly as I can in the next 30, 45 minutes. But again, if I can't cover it all, whatever is left, I will absolutely for sure cover in the videos or in the additional class. So, um, and Sarah, did you have any questions before I get going?
No.
Okay. All right. Um, and just to remind everybody, I'm sure y'all are great. Just make sure you have your final exams completed by Thursday. I try to send out email reminders, like just begging and pleading people to please take your exam. But I will get probably 4 or 5 emails Friday night from students saying that they were off a week or that that's the first time they've ever checked into the course and they're wondering why they're not passing. So please get those done. I'm not worried about y'all too. I'm just saying that because this will be recorded and hopefully one of those people are watching right now. Let's talk about trauma in the brain and development, because I would say apart from, yeah, I would make such a statement that there are really two things that shape our brain through childhood and adolescence. It is our genetic predisposition, the skeleton framework of how our brain is going to be shaped. That's why, our kiddos that we have, our traits, even as infants and toddlers, before they learn anything else. Um, my daughter, for example, used to walk on her toes like a lot, and I did the same thing as a kid. Um, she never saw me walk on my toes. She was just born with that, right? So we've got genetics. The other side of that equation, and really I would classify it as this, is what shapes our brain is our response to environmental stressors. And or I would say our exposure to environmental stressors. That's probably a better way of saying that. I don't know. I probably need to say both. I would say it's our exposure and our response to environmental stressors that shapes our brain. And when I say stressors, not necessarily meaning like trauma stress, although we will talk about that. Stressors meaning uh, environmental stimuli, context situations that produce a stress response in our brain. Because bottom line, our brain cares most, if not all, about our survival. From day one, our brain its job is primarily and only, I would say solely, trying to learn information and prioritizing its learning of that information in response to what is most likely to keep me alive. Now, we don't walk around as kiddos like, okay, well, I got to learn these survival skills. It's not a conscious process, but neither is neurodevelopment. My point, though, is that when you think about stress as being, there's a good amount of stress, and then there's a bad amount of stress or a pathophysiological amount of stress. And that line or that distinction between what's good or what's good for shaping the brain versus what's too much is a moving line and highly dependent on genetic predisposition, the person's age or the child's age, and a host of other factors that can be related to, like, whether or not the person is or the kid is sick frequently, or whether or not the child has parents who are available and emotionally supportive and psychologically helpful and not harmful. Not just parents, guardians, so forth. But my point there is that the DSM-5 TR has a distinct cutoff of, like, these people have PTSD and these people do not. These kiddos have PTSD and these kiddos do not. But that distinction is not in line with what we know about the brain, because that distinction is something that changes, and it's dynamic over time, where a 3-year-old can develop PTSD from watching the wrong kind of scary movie as compared to an 11-year-old, right? And I can tell you, just from personal experience, having watched The Shining, should never have watched The Shining. I would not recommend anybody watching it. But I watched it when I was like 6 or 7. I was little. And I still have nightmares, recurring nightmares about that show, and I will not watch it. Mm-mm. And those little twins, nope, it's not going to happen. The point with that is that, now, is that PTSD? Probably not. Was it PTSD? Possibly. Now, the DSM-5 has a very concrete definition, though, right? So by watching that, I was not exposed directly or indirectly to actual harm physically of myself or somebody else. Or, nor was I going to die from watching that. But my brain at the time does not care about those words at all, because my brain at the time, developmentally, perceived that movie in such a way that it thought it was a threat, which is why I developed PTSD-like symptoms as a result. And I guess my overall point with that is, as we talk about PTSD and trauma and even anxiety disorders and things like that, I want you to remember is that to try to designate a concrete definition for and separate every single person on the planet and every child on the planet as being either, you meet this diagnosis or you don't, that's an impossible feat. It's a spectrum that we're talking about. And it's a spectrum that shifts over time depending on how our frontal lobe is doing and its ability to regulate our stress response. Okay? Does that make sense so far? Okay. So, the stress response at its most fundamental level, I'm going to back us up real quick. The autonomic nervous system, right? We've got the central nervous system, which is our brain, right, and our spinal cord. Our peripheral nervous system, which is everything that's not the brain and the spinal cord. And then the peripheral system and the central nervous system has components of the autonomic nervous system or automatic nervous system. In other words, you don't have to think about, thankfully, you don't have to think about digestion. You don't have to eat a hamburger and be like, okay, now I got to concentrate on breaking that food down in my stomach. Thankfully, we don't have to do that. We'd be exhausted, right? We also don't have to think about, thankfully, uh, if we're walking, let's say, to our car, and this happened to me the other night, and it's always a cat. I don't know why. There's a cat underneath my car. It was at night. I was having a great day up until that point. Went to go unlock the car, and a cat just went like meow, just like jumps out, like they just out of a movie, like a cartoon character, and terrified me. Thankfully, I did not have to think about like my fight or flight reaction, right? Which was mostly flight, because I have a tendency to run whenever my fight or flight kicks in. I wish I was a fighter, but I'm just not. I'm a flighter almost every time. Anyway, we don't have to think about that. We don't have to think about that kind of stuff, and that's the autonomic nervous system. Now, that's all unconscious stuff for the most part, except we also have a brain that's pretty cool and pretty good at intentionally, if you train it anyway, you can make your autonomic nervous system kind of do what you want when you want to. So, in other words, we teach things like deep breathing, right, and progressive relaxation. Even some of the EMDR stuff hinges on the ability to consciously control what is otherwise unconscious autonomic responses. We can make our heart rate go down consciously. We can make our respiratory rate go down. You can even make the skin temperature go up or down. My point there is that it is the autonomic nervous system that has both input from the brain and talks back to the brain to tell you how you're doing. And I'll give an example of that is that most people who have panic attacks, including kiddos, by the way, not most, I'd say a large percentage have heart rhythm abnormalities, such that sometimes you're just walking along in life and you're not nervous or anything. Your heart, skips a beat or has a dysrhythmia, and it talks to the brain and tells the brain, you're dying. Because that's the only message it can send. It can either say, you're doing okay, or you're dying. And most time it's saying you're doing okay. But as soon as that message turns to you're dying, your brain, before you can even consciously process it, your brain sets off a stress response, an acute stress response, which in turn speeds up your heart rate, which in turn sets off the fight or flight. So a lot of people who have panic attacks, by the way, it starts with a heart rhythm abnormality. That's an unconscious thing. And then what happens is it gets conditioned, because now eventually the frontal lobe catches on. It's like, whoa, what's going on? I feel nervous and panicky. I can't breathe. I think I'm dying. And so then the brain consciously learns or is conditioned, whatever is in that environment, whenever that panic attack or when that heart rhythm abnormality occurred, is now a conditioned stimulus, just like the bell, Pavlov's bell, when he rang, to cause a panic attack. So it goes from like a physiological cause to a psychological one, to where you can even correct the heart rhythm abnormality afterward, but people will still continue having panic attacks because the brain was conditioned as such. Now, I use panic attack as an example because the stress response of fight or flight really is the core feature of what happens with PTSD, at least in the beginning. And I'll say this is that, going back to what I was saying earlier about our brain is always trying to learn what is likely to harm us or kill us. And so anytime we're exposed to an event or something that we perceive as threatening to us, our brain is really good at remembering that, as compared to, you know, your child and adolescent development, child and adolescent psychopathology professor's lecture, right? Where, your survival probably doesn't hinge on that as much as it does whether or not I'm going to anticipate a cat jumping out from underneath my car every night. But a point there is that your brain is so wired for remembering that stuff that when the fight or flight response occurs, it immediately causes causes a child's brain, adult's brain, same way, to develop a concrete memory and context around that event in anticipation that if I'm ever in this event again, I can avoid it intentionally, or I'm going to be on high alert because it might happen again. And that's a benefit. I mean, if we didn't have that built in, we would not live long. Where PTSD comes from is you have that occur, but it was either of such a severity or so prolonged that the brain not only remembers it, but is unable to forget it. Meaning, there's a lot of stuff that happened to you when you were, 2 and 3 years old that were terrifying to you at the time, but that you don't remember, nor do you even have a fight or flight response about, because your brain was able to forget it. I'll give you an example. At one point in time, when you were crawling as a baby, you came up to you know, uh, carpet to hardwood floor, separation. That's the first time you ever encountered that. Your brain thinks that hardwood floor is not safe because you never touched it before. And maybe somebody put you down on it and you maybe had a big crying spell, and that was traumatic for you at the time. But you probably don't remember that. And the reason why is because your brain was able to forget it, is eventually able to undo that trauma by saying, hey, no, that's not really traumatic. It was okay. You survived. It's okay to crawl or walk on the hardwood floor compared to the carpet. With PTSD, unfortunately, the brain never does that. That memory not only gets stuck and associated with whatever stimuli that was severe or prolonged, that was traumatic, but it also starts to get generalized like a panic attack to other stuff. So, in other words, people who've had like a motor vehicle accident, for example, I'll give you an example. Kiddos, like they're riding in a car, they have a car, there's a car wreck. Even a lot of times when it's just a fender bender, by the way, it's still pretty traumatic for kiddos. They will, for a long time, avoid getting in the car and be very anxious and nervous, like even talking about cars or having to ride in a car, things like that. And that's one of the symptoms of PTSD, right? The avoidance of the stimuli that reminds us of that trauma. Um, so with PTSD in kiddos, it's a little bit different. Long story short is that kids, as compared to adults, tend to exhibit much more difficulty in a couple of things: attention and concentration deficits afterwards, and irritability and explosive anger and irritability. So, really, to make it a little bit more simple to say, kids with PTSD, both kids and adults with PTSD, have a hair trigger fight or flight response now. Adults with PTSD, for the most part, are wavering between the ability to put the brakes on that response when they need to or want to, and then unable to, which is why you'll get adults with PTSD who still have explosive anger and or explosive episodes and kind of that fight or flight response so quickly. But kids, because their frontal lobe's not fully developed, will have a much greater difficulty with that compared to adults, especially when they're triggered. This is why, by the way, I think it's so important to remember for kids at school and discipline, because a lot of times what happens is they've got some sort of PTSD related trauma, either ongoing or having occurred in the past, and associated with like an adult yelling at them, let's just say. And then they go to school and they get in trouble. And then all of a sudden they've got another adult like yelling at them or like in their face or confronting them. And as an adult, most of us are able to kind of put the brakes on that fight or flight, even though we might be feeling it internally. We're aware of it. We can put the brakes on it. Kids can't. And so you'll see kids who get in trouble at school who have PTSD who end up acting out even more so whenever they get in trouble, simply because it's a fight or flight response. So with that said, how do we treat PTSD? The treatment of PTSD is always a combination of, I would say, at least two things, if not three. One is time, and or another way of saying that is temporal separation from the stimuli that caused the trauma initially. So the longer we go in not experiencing the same stimuli, the less PTSD symptoms there will be. Now, by itself, sometimes it can take years and years. And in fact, there's some research to support that you can have a reemergence of PTSD symptoms, almost like what's called an extinction burst, even if you've had the trauma happen when you were a child and you're now 60 years old. But in general, time plus some sort of desensitization or systematic desensitization would be the best way to, clinically officially label it, in the form of therapy, and then in some cases plus medication. But here's the thing, PTSD, let's see if I can, causes your amygdala, or causes a child's amygdala to be revved up. So you think about the amygdala as a fight or flight, like it's the fear response beginning. So whenever I saw that cat, before my frontal lobe was even aware, my amygdala was like, yep, this is it. Life's over. This cat's got me. It's just catastrophic. Now, the amygdala for everybody has a temperature. Let's look at it like a thermostat. Genetically, everybody has a different temperature. The higher we go, the more stressed out we are. The lower it is, the less stressed you are, probably the more sociopathic you are. But when we experience trauma, it causes that thermostat to reset to a higher temperature gauge so that our baseline temperature increases and that the amygdala is more and more ready. It gets more and more hypervigilant, so to speak, to anticipate something bad happening. When that happens, that means that your tolerance and threshold for what is traumatic or what causes a fight or flight response is now lower. So in other words, you've got an amygdala, let's just say it's at 70 degrees normal. A child experiences some sort of traumatic event, bumps it up to 80 degrees now, such that it is more likely to experience something as traumatic that it otherwise wouldn't have, since we have a past history of trauma already. I think that makes sense. But my point again with all of this is that the brain is really good at remembering trauma. It's really good at remembering things that are likely to interfere with your success and survival. The more often you encounter something that threatens your survival, the more hypersensitive your amygdala becomes, which in turn is a positive feedback loop to where the hotter it gets, the hotter it's going to be. It just keeps producing, it decreases your ability to tolerate stress moving forward. And this is where things like complex and complicated PTSD, like the C-PTSD, comes from, some of the theories. The good news is that compared to adults, kiddos, that part of the brain is still in development. And so where a 30-year-old who has a motor vehicle accident, I keep using that as an example, but a 30-year-old who experiences trauma, where it might take a decade of separation between experiencing any trauma in order for the brain to cool off and for that thermostat to crank back down. For a kiddo, it might not be as long. And especially with intervention and treatment, it's more likely to crank it down quicker because the thermostat's still being built during neurodevelopment. Okay. I'm trying to be mindful of the time. Karina, did you have any questions about PTSD before I move on?
No, that was very, very comprehensive. I appreciate it. Thank you.
Good, good. So I want to talk about OCD, obsessive compulsive disorder, and this is probably what we'll wrap up with tonight. And then I'm gonna just plan on either those videos or the extra class. But it's a little bit of a switching gear, but it is at least partially related to everything we just talked about. OCD, here's what you need to remember about OCD. Obsessive compulsive disorder is built into our brain in the same way that PTSD is. It's an adaptive mechanism, because if you did not have OCD for water, then you would die very quickly from dehydration. In other words, you've got a brain, the same part of your brain, really right pretty close to the amygdala, that cares about your survival. Right next to it is the hypothalamus that deals with your sense of thirst, that monitors how thirsty you are, helps you perceive being thirsty. And the thirstier you get, the more you begin to obsess about water. And then eventually you will, in order for that to go away, you will be compelled, or you will act compulsively in seeking water to make that obsession go away. That's OCD. That's 100% OCD. It's the same part of the brain, by the way, that lights up in all the diagnoses that we talk about under the category of OCD in the DSM-5. But if you think about it this way, whereas it's, I would say, healthy that we have a built-in mechanism for seeking water, it's not necessarily healthy that OCD sometimes causes us to perform very specific routines at night in order to go to sleep. For kiddos, by the way, you'll see this emerge as like personifying like Had one kid one time personify the door frame of a house or to their room, meaning that they had to, if they didn't walk in the doorway correctly into their room, they would begin to obsess about whether or not they hurt the doorway's feelings. And then in order for that to go away, they would compulsively have to do it the correct way, and often would take multiple attempts, causing them to not go to sleep at the time that they were supposed to. Or I've had kiddos like brushing. It's always like around personal hygiene, by the way. I'm not really, and typical daytime routines is another one that's just common. Brushing their teeth. I'll often hear kiddos talk about having to brush the same, like they count how many times they brush their teeth on each side. It's got to be exactly the same. And they've got to make sure they've gotten every tooth the exact same amount. And they usually have a very specific number, by the way. It's one question you can always ask a kiddo or an adult is, what's your favorite number and why? They'll often tell you, well, it's 7 because that's exactly how many times I have to brush my teeth on each side. That's OCD, because you can brush your teeth 6 times and not 7 and still survive. So what happens with OCD is that the part of the brain that deals with water, the thirst, right? We want that. But for whatever reason, there's multiple theories out there, one of which is an autoimmune theory, by the way, that OCD will develop when the part of the brain that deals with water and thirst and hunger and other drives generalizes. In other words, that function spreads out and branches out from just that localized area and starts to include stuff that's not related to thirst and hunger. But food is always really nearby, meaning our brain also has an OCD like quality in related to things that make us feel disgusted. Food being the most powerful form of disgust. If you've ever gotten sick, like food poisoning, probably a good chance that you have avoided whatever food that is for from there on out, even if it was just once in 100 times event. But that's because your brain's real good at learning, first of all, what's important for survival, but secondly, when you see that food, all you can do is obsessively remember what happened. It gives you a deep sense of disgust. Well, as it turns out, there's a part of your brain called the insular cortex, which is right here. You see this is the OCD dimensions: symmetry, taboo thoughts, contamination, hoarding, and food disgust, and even like psychological, like personal disgust. So like if you fail a test and you're disgusted at yourself, the part of your brain that lights up, or that you, and the reason why you can even have those thoughts is because that part of your brain deals with those thoughts. But that part of the brain also is the brake pedal, or part of the brake pedal, because it's deeply connected with the frontal area. It is the filter for all of the obsessive thoughts that everybody, or intrusive thoughts that everybody has on the planet. Intrusive thoughts are the highlight of OCD. That's another thing that you need to remember about OCD, is that OCD comes with intrusive thoughts. What is an intrusive thought? An intrusive thought is when you're just sitting there, just thinking blankly about anything else, and then all of a sudden something scary or frightening or disgusting pops into your mind. And in most cases, we're able to say, well, that's strange, and then just filter it out and redirect our attention to something else. That thought becomes intrusive, though, when we can't do that. This happens a lot when you try to sleep at night. So you lay down, go to sleep. It's been a long day, and all of a sudden, You shoot back up, you're wide awake because you wonder, did I turn in this assignment, or did I do this at my work, or did I lock my car? Your brain is on high alert. It's like, okay, this is important. And then you're like, it'll be fine. But for whatever reason, at night, it's not for whatever reason, there is a reason, but at night, you can't make your brain stop thinking about that once you started thinking about it. So it keeps you up. It's all you can think about. And then you start thinking about solutions to that problem. Or you might even wake up and get up and actually go do it, because if you don't do it, you won't be able to sleep. That happens at night, by the way, for a biological reason. That's because your norepinephrine and your dopamine levels in your brain, which is your frontal lobe juice, it's the brake fluid for the brakes that put the brakes on, that filters out all those thoughts. Those things decline at night, because if they didn't, you wouldn't sleep at all. And so you're more disinhibited at night than you are during the day. Your frontal lobe doesn't work as well, and it has a harder time filtering out those intrusive thoughts and putting the brakes on compulsive behaviors. That's why kiddos, by the way, with OCD often have sleep difficulties, because they cannot turn their mind off at night, and they, especially as it relates to routines that they might have before going to bed. Yeah. And I am going to have to pause this there. I know that was very, very quick, but actually the last thought I'll say this, the last note I'll make about OCD, going back to the neuro or the autoimmune piece, is that OCD absolutely does tend to run in families. Also, as a side note, and you don't have to remember this part, but I've never met a person with OCD who didn't have ADHD. I don't think they exist. Not because I think ADHD explains everything. What I'm saying is ADHD is a subtype, of which OCD is also a subtype, of which several other things are also subtypes of something else that's really more accurately defined as like a frontal lobe syndrome. But OCD there are some diseases and some autoimmune conditions that appear to cause OCD directly, even without any other like predisposition for it outright. For example, pandas. Here's one example: pediatric autoimmune neuropsychiatric disorder associated with strep. Now, strep is present on everybody. Every kid eventually gets it. Doesn't mean that everybody that gets it's going to have OCD or develop pandas, but pandas is associated with a very quick onset of OCD symptoms following, usually within about 2 to 3 weeks after some sort of strep infection. And I've seen it happen even up to like 6 to 8 months after a strep infection. Usually in early childhood, like between 4 and let's just say 8, where the child is like, living normal life, and all of a sudden they get like a strep infection, of like their tonsils or something, whatever it is. And then a few months later, it's almost like overnight. They wake up the next day and they are a different child, and they have OCD. It's usually like with like taking showers or being incredibly anxious in social situations. I mean, it's really like night and day difference. So much so the parents are, I mean, of course, concerned and worried. So they bring their child to a therapist or psychologist, psychiatrist to figure out what's going on. And as it turns out, there's quite a few of these folks out there, and probably, this is my hypothesis, it's not backed by the research literature. So if you come across it in the test, Karina, just forget I even said it. But probably all OCD is autoimmune related. And it's not just strep, it's probably associated with all kinds of like infections or environmental triggers, pathogens. And what we do know is that when you have an immune response, what that means is your body produces antibodies, right? So you get strep for the first time, your body's like, whoa, 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 what is this? No, it's cool. We've got it covered because what we'll do, we'll make some antibodies so that if we ever encounter it again, it won't kill us. So it produces these antibodies that circulate through our body. With some of these kiddos that develop pandas and OCD, what's happening is those antibodies attack or attach themselves to the OCD network, the same part of the brain that deals with thirst. Same part of the brain that we've been talking about. It attaches to those receptors or to those cells and those pathways and causes the immune system to intermittently attack those systems. And when you attack those systems, guess what results behaviorally? OCD. It's also why you see it, by the way, you see it in older adults who have like stroke in that area of their brain, or even vascular dementia or Parkinson's, by the way. All of those conditions affect the same part of the brain that when I'm talking about the thirst OCD part of the brain, that hypothalamic or hypothalamus, amygdala, insular cortex area, basal ganglia area. And when you have an antibody that attacks that area, it causes OCD, which is why OCD waxes and wanes in presentation. Even if it's not pandas, if it's OCD, that means you're going to have time periods where you've got a lot of symptoms, and then other times you're not going to have any symptoms. You're not going to meet the diagnostic criteria for it. Doesn't mean it's gone away. It's just in remission. That's the best way to think about it. And some people probably have more sensitive immune systems such that they have more regular recurring cycles of OCD, and other people don't. But we don't know exactly why yet. And there's a lot of debate on whether or not any of that's true, to be honest with you. But everything is pointing towards there being an autoimmune connection there, and probably in every single case of OCD. I would argue too, by the way, that the stress response and the exposure to trauma or exposure to stressors and how much stress hormones we have going through our system at any given time might play an additional role into the development of OCD. Because what is PTSD? PTSD is just another form of OCD. It's an obsessiveness where they can't stop thinking about the trauma, and then a compulsiveness to stay away from it, right? It's all the same part of the brain. All right, I'm gonna end this there. But Karina, do you have any questions for me at all?
I have two unrelated questions and are really quick. One is when I went to try to do quiz for week number 2, it told me the quiz closed on Thursday, February 9th.
That's strange.
Or Thursday, February 19th, or it didn't let me open it.
Okay, I will reopen that because it shouldn't have done that.
Yeah, and then the final, it's not posted yet, right?
The final exam?
Yes, sir.
No,
earlier.
It is. It's at the very, very bottom of the page.
Oh, I thought I didn't see it. I went to, there's a little cartoon-like kind of thing that it's crossing the line and everything, but I couldn't see the link. I'm gonna look again. Maybe it's just me. is
Oh gosh, why does it
I'm
say
gonna-
March 11th? Oh wait, hang on. I was on the wrong one. Whew, that scared me.
Oh, never mind. It's here. It's here.
Yep.
I didn't see it. Yeah. The final exam is there. Week number 2 is the only one that. Let me double check. Maybe it was also me.
I can fix that if I didn't. No, it says it closed on February 9th, but that's not accurate. Let me open it back up.
Yeah.
Thank you for letting me know. I'm sorry about
Oh,
that.
you're welcome. No, it's no big deal. I figured I would see you, tonight, so I would just
Sure.
ask you when I saw you.
But I've had a few folks asking about that. I don't know why that did that. I had them all set up for the right time.
Yeah.
Yeah.
Yeah, I remember looking at it a couple of weeks ago when it did have all of them for the 23rd, but
Right.
this weekend when I went to look at it, it just said that.
Yeah. So now
Everybody else is good. I mean, everyone else is good.
okay. Yeah. So I fixed that. It should work. Can you double check on your end though before?
Absolutely. Yes, sir.
Okay.
Let me just look. Let's see. I'm going to refresh my page so that it shows me. Let's see. Updated version. Week 1, week 2, week 1 quiz, week 2 quiz. Yes, sir. It's updated. Thank you.
Perfect. Absolutely.
Mhm.
Thanks for letting me know.
Oh,
Well, hopefully, at least some of this stuff we covered tonight was helpful. And then, like I said, I'll either get those videos posted or I will be offering another class. Okay.
all right. Awesome.
Uh,
If you do the class on Thursday, unfortunately, I won't be able to be there, but I will watch
mhm.
the recording.
Sure. Well, I'm gonna shoot for Wednesday because Thursdays are a hard day for my kiddos because they've got like practice and stuff. But yeah, so I'm gonna shoot for Wednesday if yeah, but hopefully I'll be able to get videos too. So, alrighty.
Okay. Many of us have finals, like other classes finals.
Yeah.
Like
Yep.
I have trauma class on Wednesday, so I won't be there either. But I'll see you next term anyways. I signed
Absolutely.
up for
And
the geriatric for spring.
sure, absolutely. And I'm hopeful that not hopeful. I'm certain that by next semester, my role in this will be in this forensic thing will be done for a while until at least September because that's when the trial stuff is. So,
Mm.
um, all righty. Well, it's good to see you again. And yeah, just let me know if there's anything else that you need in the meantime.
Awesome. Thank you so much.
All right. Well, take care.
Have a good day.